Okay, so we're talking about now about managing diabetes in pregnancy. And we're going to talk about pre-gestational diabetes, but also about gestational diabetes. So if a patient has pre-gestational diabetes, pregnancy may actually accelerate those vascular complications. Remember, the long-term complications of diabetes are damage to the blood vessels and damage to the nerves. Pregnancy can make that happen faster. In early pregnancy, they may need a decreased insulin dose. Later in pregnancy, that need may increase, and then postpartum, they again need decreased doses. For gestational diabetes, we want to screen between 24 and 28 weeks. Earlier, if they're high risk, there are different ways that we screen for that. There's a 1-hour glucose tolerance test. They consume a specified amount of glucose. If the blood sugar is over 130 to 140, it's a positive screen, and they get followed up with a 3-hour oral glucose tolerance test. When the 3-hour test, again, they consume a specified amount of a glucose containing fluid, and then they're checked at specific intervals afterward. And if 2 or more values are elevated, then they're diagnosed with gestational diabetes. So how do we take care of the patient who is diabetic? In the prenatal setting, Antipartum Care, we need to do a complete assessment of the mother's health and glycemic control, ideally before they conceive. Frequently, that's done at the first visit because a lot of people don't plan their babies. One of the things that needs to be evaluated is renal function. Remember that vascular damage is going to affect kidneys earlier. A UA and culture is done at the first prenatal. UTI is more likely to have severe consequences. We want a hemoglobin A1C if that patient is already diabetic to see how their control has been. They're going to have more frequent prenatal visits every 1 to 2 weeks in the first trimester, and then 1 or 2 times a week in the last trimester, because the complications mostly can be prevented or predicted. We want really good, tight blood glucose control during pregnancy, because poor control actually makes all those complications more likely. Hypoglycemic precautions. Remember the risk of hypoglycemia, especially if they're being really aggressive with insulin to have good control. So they need to have a medic alert bracelet. They need to have a source of quick sugar on their person at all times. Meticulous skin care and foot care. Remember the risk of wounds in patients with diabetes. Nutrition counseling to make sure their diet is optimized. Exercise as advised by their primary provider. Women who already have complications from diabetes, we need to be cautious with exercise because we want to be careful about increasing oxygen demand. Insulin is usually used to manage diabetes in pregnancy, even for type 2 or for gestational diabetes. There are some oral diabetes meds that are now beginning to be used a little bit. For a long time, it was always insulin. Now we're starting to use some oral diabetic meds for those patients, but some of them are not safe in pregnancy because they can cause birth defects. So insulin is still more common. Blood glucose levels need to be checked more often than they usually do, and insulin needs to be adjusted for that. We want lower target levels during pregnancy because we don't want hyperglycemia. So fasting blood sugars, we want 65 to 95, 1 hour postprandial less than 130 to 140, 2 hours postprandial less than 120. So we want to keep them really well controlled. They get increased fetal monitoring. Ultrasounds are done several times through pregnancy to monitor growth and development. A maternal serum alpha fetal protein, MSAFP, that's part of that second trimester screen that they do. We want to see that because it's going to show if they are, it's going to screen for neural tube defects, and diabetes increases the risk of that. A fetal echocardiogram may be done if this patient's considered high risk. Because diabetes, especially poorly controlled, can lead to cardiac defects. In the third trimester, we want them monitoring fetal movements daily, and letting us know if there's a change. In the last 1 to 2 months, they get an NST and a BPP either weekly or twice a week for the last 1 or 2 months of pregnancy. An NST is when someone is put on the fetal monitor and we're monitoring for signs that that fetus is reactive. They're able to respond to changes in the environment. There are specific things that we look at in the fetal heart tracing. We're going to go over that when we move into I think Ms. Durant goes over that, but we're going to go over it a lot more in depth when we move into labor. A BPP is an ultrasound that looks for very specific things, and it's measured on a 10-point scale. For gestational diabetes, typically they don't have diabetic complications. Those vascular complications take time to happen. So for gestational diabetes, usually we're going to start with diet and exercise, and then insulin is added if it's needed. More recently, glyburide and metformin have been used. For gestational diabetes, if they have some comorbidities, if they have hypertension, if they have a history of stillbirth, or if this fetus is expected to be really large, then they're going to get that extra monitoring. But remember, the extra monitoring for a patient who was diabetic prior to pregnancy is because they already probably have some vascular damage. Patient with gestational diabetes has not developed that vascular damage yet most of the time. In labor, delivery is planned to minimize the risk. So because of the vascular effects of diabetes, the placenta tends to age early. It's a vascular organ, we get damage to it, and it starts to kind of age and not work as well early. But diabetes slows lung maturity. So they try to time it so that we have mature enough lungs, but before the placenta gives out. We really don't want this patient going post-dates, but they try to time it close to term so the lungs are mature. This may be part of the reason, especially with the patient at higher risk for complications, that they're monitoring more closely. C-section should be considered if the fetal weight is estimated at greater than 4,500 grams if the mom is diabetic. And that's because the combination of diabetes and a large baby is a much higher increase in risk for shoulder dystocia. Glucose and hydration status of the mom are monitored really closely while they're in labor. IV usually is going to be normal saline, and it's changed to some glucose-containing fluid if they get hypoglycemic or when they get into active labor. So we start out with normal saline and then add some dextrose later. If they need IV insulin management in labor, this is usually going to be for a type 1 diabetic who's been diabetic prior to pregnancy. An insulin drip might be used to maintain blood sugars. Blood glucose is monitored, the dose is adjusted hourly. The only kind of insulin that we put in an insulin drip is regular insulin. One other thing to know about an insulin drip, when you add insulin to your IV, you add the insulin before you spike the bag. If you spike the bag, prime the tubing, there's a lot of fluid in that tubing. So you add your insulin after that, it might be hours before that fluid with insulin in it actually gets to your patient. So you add the insulin to the bag and then you prime the tubing. For gestational diabetes, blood glucose levels still may be monitored hourly, and we want to just maintain their blood sugar within a normal range. Usually they're a little bit easier to maintain. Postpartum, the first few days, insulin requirements decrease. So we're going to again be monitoring them really closely to make sure that they're not getting hypoglycemic. They're still going to get that sliding scale insulin based on their blood sugars for that first several days. Postpartum, there's an increased risk of hemorrhage, infection, preeclampsia, and eclampsia. So those patients need monitoring for a couple of days for those issues. Contraception is recommended. We don't want back-to-back-to-back pregnancies in a patient with diabetes, so we recommend contraception. Any hormonal method of contraception has an increased risk of blood clots, which is already increased in that patient with diabetes. And so they might be encouraged to choose a different method. We do encourage breastfeeding. It decreases the child's risk of diabetes. It also decreases insulin requirements while breastfeeding. But women who are diabetic, their milk may come in a little bit later. They may have a delay in milk production. For gestational diabetes, most patients who've had gestational diabetes return to normal blood glucose levels after pregnancy, but it tends to recur in future pregnancies, and they're at increased risk for developing type 2 diabetes later. They're typically reassessed at 6 to 12 weeks and then tested every 3 years after that. We also want to recommend some lifestyle changes to help delay the onset of that type 2 diabetes. Sometimes someone who's developed gestational diabetes never goes back to normal blood glucose levels. So sometimes they now are type 2. Okay, that's all for diabetes. It was a lot. If you don't remember the patho and the complications of diabetes, please go back and study that, because I rushed through this section because we studied diabetes last year. So you've got to go back and pull that information out. I'm going to talk next about thyroid disorders in pregnancy.